Assalamu alaikum and good evening to you all. Welcome to the Health Talk on Acute Medicine, organized by SB Bangladesh chapter and supported by Bangladesh Society of Medicine. Today, we have come to the sixth episode of our series. On this episode, we are going to talk about another very important topic. Today's topic is about acute pancreatitis. To talk about this important topic, we have one of the most dedicated and one of the most up-to-date professor of our time. He is none other than Professor Suhail Muhammad Arafat sir. He is the chairman, Department of Medicine, BSSMU. To chair the session, we have the governor-elect of SB Bangladesh chapter himself, a true leader, a prodigy in medicine, Professor Khan Abul Kalam Azad sir. He is also the former president of Bangladesh Society of Medicine. As the panelists, we have two most renowned professors of our country. Firstly, we have Professor M.D. Ismail Patwari sir. He is the principal and professor of medicine, Sylhet Women's Medical College, and he is also the president of Bangladesh Society of Infectious and Tropical Disease. We also have Professor Dr. S.K. Abdul Fattah sir. He is the former professor of medicine, Shahid Tajuddin Ahmed Medical College. To moderate today's program, we have Dr. Faizur Rahman Fahim sir with us. He is the assistant professor of medicine, Dhaka Medical College. During the live session, you can ask topic-related questions on the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand off the session to Dr. Faizur Rahman Fahim sir. Dr. Faizur Rahman Fahim sir.
Okay, thank you, Dr. Prince, for your nice introduction. Am I audible? I first express my apology to the viewers for this unwanted delay due to some technical difficulties. Honorable Chairperson, respected teachers and learned viewers, very good evening and welcome to this episode of Health Talk on acute medicine that is organized by SCP Bangladesh chapter and sponsored by Bangladesh Society of Medicine. Today, we have a very important topics to discuss that is acute pancreatitis. Acute pancreatitis is a medical emergency which account for 3% of all causes of abdominal pain, and it has a good mortality that is about 10%. To discuss on this important chapter, we have with us one of the most talented internists in Bangladesh, Professor Sohail Mahmood Arafat sir, chairman of Medicine Department, Bangladesh Sheikh Mujib Medical University, and he is also the current Secretary General of Association of Physicians Bangladesh. It is our great pleasure to have one of our mentor, the maestro of internal medicine, the legendary professor, the living legend, Professor Khan Abul Kalam Azad sir, with us as a chairperson. And Professor Azad sir is elected governor of SCP Bangladesh chapter, former president of Bangladesh Society of Medicine. He is former principal of Dhaka Medical College and currently principal of Popular Medical College. We have a very good expert panel today. We have two eminent professors, a good teacher and great physician of Bangladesh. One is Professor Ismail Patwari sir. Ismail Patwari sir is currently principal and professor of medicine in Women's Medical College, and he is also the president of Infectious and Tropical Society of Infectious and Tropical Disease. And we also have with us Sheikh Abdul Fattah sir, who is a former professor of medicine, Shahid Tajuddin Medical College. Without any further delay, I humbly request, with the permission of the chair, I humbly request Professor Sohail Mahmood Arafat sir to deliver his speech. Sir, please.
Thank you, Dr. Fahim, for your nice and kind words and nice introduction. With the permission of our Honorable President-elect Professor S.B.M.MU, sir, the SCP Bangladesh chapter, I'd like to start my session. At the very beginning, I'd like to acknowledge my gratitude to the SCP Bangla chapter for as they have selected me for this topic. Also, I want to express my apology, personal apology for some technical delays. We have to start a little bit late. Okay, let's move on our topic. This is acute pancreatitis. This is the one of the most important emergency intake in any acute hospital who comes with acute abdominal pain nowadays. Previously, peptic ulcer disease was a most rampant disease, but nowadays that has been a little bit less in our common practice. But it is a really a serious hill for us to handle this sort of acute pancreatitis, though there is dilemma. It is a medical or it is surgical. So it already, the thing is that acute pancreatitis, Dr. Fahim has already said that already this is a real emergency and this is one of the more important cause of mortality who comes with acute abdominal pain in any hospital setup, not only the developing country as well as developed country. Just little bit anatomy, the pancreas has two organs. There is two organs in a single gland. One is exocrine, one is endocrine. The exocrine almost takes about 80% of the structure of the pancreas, and only 2% is endocrine parts, and other parts is supporting structures like stroma, connective tissue disease, and others. So this is the exocrine part of the pancreas, which is really cause this pancreatitis, which is really affected by acute pancreatitis mainly. And endocrine part is later on, subsequently as a complication of affecting the exocrine parts. So, and long ago, when we were first year, we have known that anatomy, that and it has got two type of cells, acina glands and islets. This islets is the things who had secretes different type of hormones which regulates the mainly blood sugar, and they're composed of few cells as alpha, beta, delta, PP cells, and epsilon, and those secrete ghrelin. But that is not the point of interest today. Today, main interest is exocrine function of the pancreas, which is mainly affected or caused this attack of acute pancreatitis. So there are a lot of enzymes just digesting carbohydrates, fatty acids, fats, as well as the proteins. So trypsinogen, chymotrypsinogen, proelastase, procarboxypeptidase, lipase, phospholipase A2, and so on, amylase. And these are the enzymes which really instigates the acute pancreatitis. If you look back a little bit pathogenesis, you can divide this acute pancreatitis three phases. First, initial phase, second phase, and third phase. And initial phase, the trypsin, that is activated from trypsinogen by lysosomal hydrolases like cathepsin B. And this causes the interpancreatic other digestive enzyme activation and acina cell injury. And in second phase, there's activation and contraction and sequestration of leukocytes and macrophages in the pancreas, and resulting in NS interhepatic inflammation. Also, it causes trypsin activation. So trypsin is double activated once is by cell by some other factors. Also, the chemotacted the neutrophils, which causes the activation of trypsins. And the third phase is effect of this activated proteolytic enzymes and cytokines released by the inflamed pancreas. They acts on distal organ, which causes the involvement of the causing the multi-organ failure, namely the cardiac, renal, and respiratory system. This is a little bit busy, so I'm sorry about that, but it's the basic pathophysiology which really happens with the acute pancreatitis. That is initially, I just showing my arrows, that is trypsinogen that is being activated by pancreatic cell damage that may be caused by gallstones, may be caused by local injury. Also, it can be activated some exotoxins, endotoxins, viral infection, ischemia, osteoarthritis, lysosomal calcium, and so on. And this causes activation of trypsin, what I have said before. And this trypsin activates the kallikrein, kinin, and coagulation factor, the plasmin, which instigates or which incites the development of edema, inflammation, that also affecting coagulation factor, thrombosis, hemorrhage. And trypsin causes the protease activation, proteolysis, lipase, and phospholipase cause the fat necrosis, coagulation necrosis. Also, the elastase does directly affect the vascular walls, the elastin fibers, causing the vascular damage and hemorrhage. And other cytokines that cause systemic manifestation, what I have said before, that causes ARDS, acute necrosis, and hypoglycemia and shock. So these are the very difficult, clumsy involvement of so many players in causing the effect of acute pancreatitis, affecting from local to systemic complications. So the pancreatitis, if we go like involvement or development of pathological changes, broadly that is divided into two groups: interstitial pancreatitis and necrotizing pancreatitis. The interstitial pancreatitis is simple inflammatory infiltration causing the pancreas swelling and leading to pancreatitis. Fortunately, this is the majority, and this has got good prognosis rather than the necrotizing pancreatitis. It is around 10 to 20% or 5 to 10% necrotizing pancreatitis, which is really devastating, which is mainly the cause of morbidity and mortality of acute pancreatitis. So I have already covered this area in the previous slides, so I'm not going there. What are the common causes? If globally, gallstones, alcohol, hypertriglyceridemia, ESCP, and trauma and postoperative. These are the major causes which are not, which really causing the acute pancreatitis. If we consider our country, the gallstone is the major cause, triglycerides second maybe, but alcohol is less common in our setup. And other things is we have to forget, we don't have, we should not forget the drugs which also may cause acute pancreatitis. This starts from azothioprine, the 6-methotrexate, sulfonamides, estrogen, tetracycline, valproic anti-HIV, 5-aminosalicylic acid, DP4, just like gliptins, so on. So nowadays, the gliptins possibly is one of the important cause of acute pancreatitis in our setup because that is very popular drug to treat the diabetic population. And so when we take the history, we should not miss the history of taking these important drugs, what is really causing this pancreatitis. There might be few other uncommon causes, mainly anatomical, some genetic causes, even renal failure and virus infections like mumps, CMV or ecovirus parasites, and autoimmune. These are very, and vasculitis in our clinical practice works with depicting tertiary care hospital. I think they get these sort of cases. Then thrombocytic purpura, hypercalcemia, and diverticulum, as well as CF pancreas. So, these cases are fortunately very rare, but unfortunately, in my practice, I got 1 or 2 cases of pancreatic disease, autoimmune pancreatitis, and some causes of mumps as well. So, though it is not that common, but we have to keep in mind when we practice in our life, in our clinical life, that we have to think of also rare causes. In some cases, no cause can be found, but we have to look into this sort of factors. Unfortunately, few causes may cause recurrent acute pancreatitis. Recurrent acute pancreatitis, among them, understandably, the occult disease of biliary tract disease. Usually, it is the common, most commonly prevalent, factor which causes recurrent acute pancreatitis, especially microlithiasis or biliary sludge, which is usually forgotten or overlooked. So we have to keep in mind repeatedly, we have to look for whether there is any sort of microlithiasis or biliary sludge. Then some drugs, all I have said, if we keep on continuing those medications which cause pancreatitis, that may cause alcoholic who are really habituated or dependent on alcohol, they will have to face sometimes recurrent pancreatitis. So similarly, the hypertriglyceridemia, pancreatic cancer, here is pancreatitis, cystic fibrosis, autoimmune idiopathic. And you know that a significant number of pancreatitis cases, we don't get any cause. We don't get any cause, and that is more or less around 20 to 25%. No cause can be found. This is the summary slide of few things regarding acute pancreatitis. Usually, clinically, this can be divided two phases: early phase or late phase. Early phase is within 2 weeks, and these 2 weeks usually patient is might be necrotizing pancreatitis or might be acute pancreatitis. But when they get complicated by necrotic collection, but gas formation or infection, they go enter into late phase. Depending on the severity, that Atlanta modified classification, they have divided into 3 groups. Sorry, there's a little slide that color contrast is not good. So mild, then moderate to severe and severe. The mild cases usually have acute interstitial nephritis, and these cases usually mild pain, might be asymptomatic, might be discomfort, but there is no local complication, no systemic complications, and usually patient recovers spontaneously within very short time, like 5 to 7 days. But in case of moderate severe, there is some sort of organ failure, like a different renal or pulmonary or cardiovascular. So this failure might affect, but for in this group, their duration is less than 48 hours. In some cases, there might be some systemic complications or local complications, but there will be no organ failure. In severe cases, there is organ failure which persists for more than 48 hours. And this severe cases usually belongs to necrotizing group. And because already I've said there is two groups, interstitial or edematous, where there's acute inflammation, and that causes the edema within the pancreas, and there is necrotizing pancreatitis. Regarding complications, there is two groups. One is less than 4 weeks, other more than 4 weeks. If the less than 4 weeks interstitial pancreatitis, that leads to acute pancreatic collection. If in more than 4 weeks, that will lead to cirrhosis. The counterpart in necrotic pancreatitis is the acute necrotic collection, which happens within 4 weeks. But when this crosses 4 weeks, they goes into world of necrosis. So this is the two parts of long-term complications. One is the cirrhosis and the wall of necrosis, depending on what is the primary cause of pancreatitis, or interstitial or edematous, or it is necrotizing. So these are same things. Another thing is that depending on this, on this morphological changes of acute pancreatitis, the Atlanta has devised definitions regarding on these morphological features. So it's understandably the very first interstitial pancreatitis or edematous pancreatitis. Yes, simple. Like that, this acute inflammation of pancreatic parenchyma and peripancreatic tissue, but there is no recognizable tissue necrosis. Necrotizing is similarly same inflammation, but there we can find some necrosis or any peripancreatic necrosis. Another thing is pancreatic cirrhosis, which I've already said. This happens in the case of interstitial pancreatitis after 6 weeks, sometimes says after 4 weeks. So this pancreatitis cirrhosis happens. Difference is that there is collection of clear fluid, which is well encapsulated and well defined inflammatory and outside the pancreas, and there's normal or no necrosis and more than 4 weeks after the onset. Another thing is acute pancreatic fluid collection. This is usually less than 4 weeks, and in these cases, there is intestinal edematous pancreatitis, and there is peripancreatic fluid collection, and it is within 4 weeks. And difference from cirrhosis is there is no pancreas, there is no well boundary or there is well encapsulated area. So this is the basic difference between these two. And in case of acute necrotic pancreatitis, there is acute necrotic collection, there is necrosis, fluid collection, pancreatic or peripancreatic, but theirs will not be encapsulated. But if and it is less than 4 weeks, and wall of necrosis, this happens in case of necrotizing pancreatitis. But when this is more than 4 weeks, and that has got well-defined inflammatory wall. So these are the two extremes of the acute pancreatitis, depending on their types of inflammation and progression. So pancreatitis, from very third year, we understand this is a very common picture we have to face in our wards. Unfortunately, the gentleman is admitted in under our unit at this very moment, Bangladesh Sheikh Mujib Medical University. It is popularly known the Mohammedans position. So this is severe abdominal pain, sometimes mild abdominal pain, depending on the type of pancreatitis. So if it is the characteristic of the pain usually is mild, then nothing important. Usually postprandial may be some aggravation, but sometimes very severe, incapacitating and causing the persistent upper abdominal pain that causes radiation to the back and leading to the really a frustrating experience for any patient having severe pain of acute pancreatitis. So these sort of presentations you will expect. In some cases, we see there is abdominal distension, that some sort of ileus development or something like that. So some nausea, vomiting, even jaundice is not uncommon when the pancreatitis affects the head of the pancreas, that causing the obstruction of the biliary channels leading to this jaundice. And on clinical examination, we can find that patient might present with something shock if he comes a little bit late. The abdominal tenderness, there will be rigidity, distension as well, and sometimes skin nodule due to skin involvement by pancreatic enzymes. And on lung examination, we should not miss sometimes massive effusion might be done, especially on the left side. Sometimes the capitation, even the features of ARDS. So all the general local, pancreatic area, there's mainly we have to look for general examination, examination of systemic as well general. In some cases, there is some ecchymosis in different parts of the body, which I will say that I'm going to next slide so you can understand that. That is great Turner sign. That's ecchymosis, a bluish area, which is usually present on the flanks. This British surgeon, Mr. Great Turner, has discovered this sign, and he has named the sign is named after him. Then the Kalin sign, this is another sign, that's a periumbilical area. He's a gynecologist. But he first noticed this sign not in pancreatitis. He found it's an ectopic pregnancy. And in some cases, we also can find the Fox signs. Fox signs is a similar sort of bluish and reddish discoloration over the inguinal, around the inguinal ligament area. So that is due to this hemorrhage or extravasation of bloods. So this is the things how this happens. This acute hemorrhagic pancreatitis that lead to periperitoneal or retroperitoneal hemorrhage, and then the mid-hemorrhage will form from the digested blood and that tracks down the facial plane, so the ligaments, and leading to this sort of findings in case of severe pancreatitis. So during our clinical examination, we also have to keep an open eye to find out these signs to give a quick diagnosis. Unfortunately, sometimes it might happen the retinopathy as well. This is also we have found in some clinical cases the purchase retinopathy. This is usually it's normally found in head injury, but in other acute inflammatory conditions sometimes lead to this finding. This is an soft exodus hemorrhage around the discal margin with retina edema. So this is another clinical sign we can expect in case of acute pancreatitis if we look at the back of our eyes. So this is called purchase retinopathy. These are some clues also. This might help in our diagnosis about the causation of the pancreatitis. You see, there's some papular eruption in the lower limbs, mostly extensor surfaces. This is the we call it that due to hypertriglyceridemia. This causes this sort of eruptive xanthoma. This is also important clue for our clinical diagnosis on make it on the bedside. So we have to also keep an eye whether we are missing these signs as well. In addition to that, we can find a tendon xanthoma, something like that for hyperlipidemia patients. Other problem is that in some rarely, this is not rarely, in few percentage of cases that patient might present with hematemesis. That is also possibly some of you might experience. This is mainly multifactorial due to it's not directly due to NSAIDs or painkillers, but maybe due to peripancreatic necrosis, which leads to this, due to releases of the different enzymes, cytokines, and there's factors from the neighboring pancreas. There is DICs and gastric erosion. So this causes the melanoma. Is usually very, around 5% cases we can find this as a presenting feature in acute pancreatitis. This is due to other complications. So after making this clinical diagnosis suspicion, we have to also we should not forget our differentials. As all of you, I understand, you know that these are the big list of differentials. Problem is that many of the differentials may mimic pancreatitis, not only clinically, sometimes even by even our investigation. like what we do in case of pancreatitis. Some the biochemical findings might match with these differences, like mesenteric ischemia, rupture protein, all causes the increases in the serum, pancreatic enzymes, raised in the serum pancreatic enzymes. So when we make a diagnosis, usually we consider 2 out of 3 criteria. That means 3 points. One is typical abdominal pain. Number 2, the serum pancreatic enzymes like lipase or amylase. And last not the least, the confirmative findings of abdominal imaging. But if you look at these 3 criteria, I think first two is very simple and economical way of making the diagnosis that is good enough to label a patient is a case of acute pancreatitis. Not all the cases will need abdominal imaging to support our diagnosis. Though, as I have said before, that some enzymes might be raised like perforated peptic ulcer, biliary colic, mesenteric ischemia, aneurysm, even decay, they may cause an increase in the level of these enzymes. But if it is more than 3 times of the normal upper limit, that usually virtually excludes other differential. So we should think that whether it is the pain is typical of pancreatitis. Number 2, whether the enzymes is good enough to cross the 3 times of its normal limit, upper normal limit. So these 2 things very simple. We have to keep in mind, but we have to do few other investigations. We have to know the different stages of our clinical management. So first, we should go for hematological investigations. So this is the characteristics or specific lab markers to make the diagnosis of pancreatitis. So what sort of things such biochemical helps we can get? There is some serum amylase, serum lipase, trypsinogen activator peptide, urinary amylase, urinary and serum trypsinogen 2 levels. But this last 3, those are not available, commercial available, that's expensive. So we still, especially trypsinogen activation peptides as well urinary and serum trypsinogen levels. But that might be a help in coming future. Till today, the amylase, lipase, urinary amylase is doing a lot in making the confirmatory diagnosis. So among these 2 enzymes, this commonly done in our practice, there's already I've said more than 3 times. But problem is that if it is 6 times, 7 times, or 8 times, that doesn't make any sense in assessing the severity. In other words, it should not be that level of these enzymes, lipase and amylase, should not be taken as a severity of the disease. So if it is more than 3 times, it's good enough to make the diagnosis, but it is not a tool to assess the severity. And if we compare to the enzymes, this is the scenario that we have seen that both starts almost early part of the pancreatitis, but the amylase comes down a little bit earlier. And so the later phase of the acute pancreatitis is not a good tool to establish diagnosis. This is the problem with the amylase. Another problem is that in some cases of pancreatitis, like caused by alcohol or hypertriglyceridemia, in both cases, the amylase might be normal, which might mislead our diagnosis if we forget to do the serum lipase. So amylase is not good tool in these 2 cases. And even in many conditions, this amylase may be raised. Some of those may be even involving the severe abdominal pain. Already among the differentials, I've said a little bit. So in these cases, they have also got high serum amylase, starting from salivary glands, the gynecological causes, endocrine cause of diabetic ketoacidosis. So macroamylasemia, a lot of conditions may cause serum amylase. So nowadays, it is someone is saying there's no to amylase, yes to lipase. That means if we do one test, we have to go for lipase because amylase is sometimes spurious, sometimes misleading, sometimes overdiagnosis, sometimes underdiagnosis. So we prefer that lipase is the most recommended investigation to establish this one. And it is as it has a lot of benefits or lot of criteria to select this as a single investigation because it's a more sensitive, more specific analysis, even elevated and useful in any phase, from starting to late phase, and also not misleaded, not increased by other causes of equivalent condition more than 3 times. So it is our choice of choice of investigations in establishing a diagnosis. The irrelevance is another our available investigation. It is better than serum MLS. It's a little bit more sensitive, but remains the same thing as like previous MLS might cause of differential, lot of differential causes of waste MLS. So though it is better than MLS, but not better than the lipase as well. So business that we have a lot of hematology investigations, starting CBC, LFTs, renal function test, coagulation profile, blood sugars. Blood sugar may be high because there is a lack of insulin, lot of glucagon, and stress hormone release, so leading to hyperglycemia. That might be imbalance or a personal. So I'm not going there. But problem is that I want to highlight these 3 important investigations because it's very cheap, it is available, and we can do at any time. Among them, CRP, hematocrit, and or urea. Among this is not to make a diagnosis. These investigations to assess the severity of the acute pancreatitis. So the higher the CRP, the more severe the pancreatitis. Similarly, the hematocrit, if it is less than 44 or more than 44%, failure to reduction at 24 hours. So this that is harbinger of a bad prognosis of severe pancreatitis. So this is a very important to what we really using in dengue fever like that. So this is another important area where this plays a very important role in assessing the severity and managing the acute pancreatitis patient. Similarly, blood urea nitrogen. That is also important because blood urea nitrogen, if it is increased, that causes great prognosis, more severe, more complication. So with these 3 investigations, keep in mind, besides other investigations, what already have said, like common CBC, silo test, and other liver function tests. Sometimes blood gas analysis is important. Here we can experience, we can see different type of acid disorders, starting from metabolic acidosis with high NM the hypokalemic, hypochromic metabolic alkalosis, and respiratory acidosis. So a lot of all the causes of different types of pancreatitis are different. Acid disorder can be developed in case of acute pancreatitis. Few investigations you have to do. The fasting lipid profile. Among the fasting lipid profile, we should give a close attention to the hypertriglyceride levels. Then serum calcium, because serum calcium that we can find hypercalcemia, which might be the cause of calcium, acute pancreatitis. Sometimes hypocalcemia, which might be due to effect of the pancreatitis, because there is lot of saponification, there is some fat is digested, or there is not affected the lipase enzymes. There's saponification that absorbs the calcium, so there's the hypocalcemia. And not the least, if no causes can be found, we have to think also autoimmune markers. So these are the few things out of the box we have to consider as a cause to investigate, as a cause of idiopathic or not obviously available recoverable cause of acute pancreatitis. So these are the bloods. Then imaging. How important is imaging? Important is imaging is that if we start the fundamental image from very early our clinical education, the X-ray. We should not forget the X-ray in the era of very advanced investigations. So the X-ray, this is important to give the diagnosis, to support the diagnosis, to rule out the diagnosis. This X-ray is similar, possibly physicians of the generation might not find it that much frequent this sort of X-ray, but when we were a student at a medical college at the time, we found almost in every admission one sort of X-ray, patient presenting with this sort of X-ray, severe pain. We understandably right dome of diaphragm, there's recently gas, so there is perforation of viscous, hollow viscous. but not is the case of pancreatitis. But this patient should be ruled out whether we are missing the perforation as well. This is another important axis in the background of pancreatitis. This is called sentinel loop signs. So we can see this. There is extended of ileus. That some part of the small intestine has been affected due to inflammatory process in the neighboring pancreas and leading to this sign. This is called sentinel loop sign. So this plain axis in and pancreatitis also sometimes some groups helps to support our diagnosis. That is very popularly seen. This is colonic cutoff sign. So after this transverse colon, there is not visible of the descending colon. Because if there is pancreatic inflammation or necrosis or that is due to involvement of the colonic walls, there is some sort of vasospasm, there is some reactionary paralytic ileus, like so. There is no gaseous distension of the distending part. So this is one of the another important X-ray signs we will read in our book, that colon cutoff sign, another is sentinel lobe sign. Similarly, this is also colonic cutoff sign. You can see the right side of the colon, the left side is not visible there. Another important axis is the chest axis, because in case of, I would say, the examination finding that in chest axis, there's a different type of involvement in acute pancreatitis. Commonly is the left-sided pleural effusion. Left-sided pleural effusion, and beside that, there might be some atelectasis, there might be features of ARDS, and there is multi-organ involvement. The left-sided effusion is important in that regard because this is also an indicator of severity of acute pancreatitis. So this pancreas may cause the left-sided pleural effusion commonly in comparison right-sided or not bilateral, less likely to be bilateral. But the main economical important investigation on the imaging is the transcutaneous or abdominal ultrasonography. Sometimes very good sonologists sometimes they might give some clues, but this is mostly important to rule out whether there is the gallstone. We already said the most common cause of the pancreatitis is gallstones. So this is very important to rule out in the gallstones, to rule out acute cholecystitis, to detect the common bile ducts dilatation, which might be cause of the choledocrolithiasis. So these are the few important information we can get by doing a simple ultrasonography, which is non-invasive, available nowadays everywhere, as well as it is cheaper in comparison to other investigations. But as a routine protocol, all acute pancreatitis should undergo the ultrasonography as soon as possible to find out these causes, which can be visible on ultrasonography. Even sometimes carcinoma, pancreatic mass can be visible by good sonologist with an expert in this field. Then the imaging, we should go for CT scan. If you say why CT? CT is a 90% sensitivity and specific in diagnosis of acute pancreatitis. And patients failing to improve, but we have to keep in mind, it is not a routine investigation. It should not be. The CT scan should not be done within first 2 days. That should not be done within first 2 days because that will not give any sort of, direction of our management plan. It is important for those who have got some sort of complications whose condition is deteriorating after 2 to 3 days. Then we have to give advice, or we have to order a CT scan of abdomen with pancreatic protocols. So this CT scan is not a routine investigation for all pancreatitis patients, and it is as the patient may develop complications with suspecting, patient might lead into necrotic pancreas, patient might develop pancreatic abscess, patient might give pancreatic collection, which may continue after 2 to 3 days. So this may be helpful in assessing those cases. And so I can show few slides these are the few slides. We can see how this helps in CT scan. If we keep eye on these slides, these all are the later phases of pancreatitis. Not within 2 days, these things will happen. So this is interstitial pancreatitis with peripancreatic collection. Here, if we look at this slide, there is the pancreas. So there is the pancreas that is little bit swollen. That is echogenic due to this inflammatory cell or hypervascularity due to inflammation. But there is no necrosis. There is some clear fluid around this pancreas. So there is no clear-cut cystic arrangement of the fluids, and the fluids is the fluid density or the CT density is like fluid. There is no heterogeneous appearance of this fluid collection. So this is the sequelae of an interstitial pancreatitis, which might lead to peripancreatic collection. So it means it is within 4 weeks. But if this happens in case of any collection which is collected there even after 4 weeks, so we can find this pancreatic cirrhosis. So understandably, it is a sequelae of interstitial pancreatitis. And in this case, if you look this fluid, this is huge and cystic appearance. There is almost no stomach is visible there. The pancreas is compressed, and there is also the well-defined capsule. So there is well-defined capsule. This leads to this confinement of the fluids, and this appearance gives the rise of pancreatic cirrhosis. So this way we can differentiate whether there's collection or cirrhosis. If you look for necrotic collection, if you go for necrotic collection, we can see there is pancreatic mass, there is some non-enhanced lesion, there is some non-enunciated pancreas, there is some fluid. If you can't see the previous one, the density and this density is not same, and there is little bit hazy and between this area. So this is the fluid collection, but this is necrotic fluid collection. It is not clear fluid like pancreatic cirrhosis or peripancreatic collection, which we see in acute pancreatitis due to interstitial pancreatitis. So this is the acute necrotic collection here. But if we go further, there is sometimes this may be infected. This may be infected, and there is non-homogeneous there. The pancreas is swollen pancreas, and in between there is some gaseous distensions, gas bubbles. There's some gas bubbles. So these gas bubbles give rise to the appearance of a pancreatic abscess. So this is important clue which the CT scan of abdomen can help us to see the complication or non-recovering or deteriorating acute pancreatitis patients whose symptoms are not improving our conventional management. Sometimes long-term that might lead to pancreatic abscess, and if you see that there is pancreas and there is some collections there is some collection that lead to this pancreatic abscess. So these are the few things which might we can get by doing a good CT scan with contrast that might lead us to reach a specific complications, which might help us to get a specific management plan for this gentleman. So this is the commonly done investigations, but we should know about few other advanced investigations, not advanced, but less available in our country. But this is really helpful in some cases, like endoscopic ultrasonography. This ultrasound is not to diagnose the pancreatitis. This is not due to diagnose the pancreatitis. This endoscopic ultrasonography will help us to find out some causes of pancreatitis, why we can find any cause, to find out some interbiliary channel deformities, interbiliary channel structural damage, or some stones. And also very good to find out the polydoccolithiasis. So endoscopic ultrasonography is a good tool to find out the causes of stones, or whether they are or the location of the stones, if it is within a common bile duct, which is not visible by ultrasonography, even might not be CT scan. In some cases, we need to do ERCP. ERCP, the endoscopic rectographic cholecystoppancreatography. This is also not a commonly done investigation. So while we will order the investigations, we have to think when we should do ERCP. ERCP should be advised only if there is features of acute cholangitis due to some biliary channel dilatations, and these cases will be a lot. This ERCP will provide a lot of help to remove these obstructions. So this is usually done within 24 to 72 hours. If we find the patient scenario matches with some sort of cholangitis, by doing some investigations, by routine investigation, bloods, also by doing some ultrasonography. So ERCP is a very important tool to treat to diagnose the condition at this very moment, because this cholangitis might lead to grave complication if it is not promptly dealt with appropriate steps. So ERCP is not needed, as I said, early gallstone pancreatitis, because this early gallstone pancreatitis, ERCP will not give any help. Rather, that might expose the patient to further depression of the pancreatitis, because that might lead to cholangitis, pancreatitis both. So this gallstone, mere presence of gallstone is not indication of ERCP. And in the absence of cholangitis or jaundice, if we like to do that MRCP US rather than diagnose ERCP to find out the other screen the location of the choledocholitis is highly suspected. What I have said before, that endoscopic ultrasonography, that is important to find out the any sort of choledocholitis if there is no cholangitis, no other clinically signs or clues. And but problem is that ERCP may lead to, when you do that, lead to some sort of deterioration of pancreatitis. And for this purpose, there is some specific they have recommended to put an prophylactic stenting there, as well as simple indomethacin suppositories before doing ERCP may reduce the post-ERCP pancreatitis in high-risk patients. So when we usually advise our patients, that might be a great help for our patients. If we suggest, if there is no contraindication, and endomethacin suppositories, that might help to reduce the post-ERCP pancreatitis. And these are the few patients conditions which might lead to the ERCP pancreatitis. So in these cases, we have to be very much careful, like sphincter border dysfunction, the minor papillary sphincterectomy. That is not in the case of acute setup. I mean, in any setup, these risk factors may invite the danger of pancreatitis. So the prior history of ERCP pancreatitis, which is a risk age more than less than 60 years, and more than 2 contrast injections in the pancreatic duct. At the end, our endoscopic trainee involvement. So that by doing an ERCP by trainee is sometimes might be risky if it is not properly supervised. And skipping that. So before that, I am saying that that's role of MRCP. MRCP and endoscopy also almost give the similar type of help in managing or in making some diagnosis, find out the cause of the pancreatitis. That is especially important for the finding out the choledocholitis without exposing the patient doing any harm by doing ERCP. So MRCP is a tool to find out in cause of choledocholitis or on interpancreatic duct litiasis. So as little as 3 millimeter diameter can be diagnosed by doing MRCP. Now, after finding the diagnosis, after finding the complications, and after finding the doing investigation to the causes of this pancreatitis, now the main point is management. The management starts in hospital, first assessing the severity of pancreatitis, which will guide us to take the patient's appropriate patient management approach. Where we should go, where patient should stay. So basically, that there are many criteria are there. The SARS capacity to then bicep score, and then what I've said before, the burn or the body nitrogen, hemoconcentration, the organ failure, cardiovascular status like low blood pressure, very high heart rate, pulmonary PO2 more than less than 16 mercury, and the renal functional status is compromised if KIT is more than 2. So there's a lot of tools are there, but it's found that if there is search score is fine at the end of 24 hours, usually that is it is less than 2, then usually that patient recovers very early and patient can be discharged very early. So thus initially within first 24 hours, we should score in different score the patients by different tools, different calculators. So that serves all of you know that all of us know that is basically 4 points: the core temperature, heart rate, respiratory rate, and the white cell count, and which might be raised more than 12,000 or less than 4,000. Both way, this is a danger for our patients, and as well as bicep score, bicep that is bedside severity equivalent score, set that is blood urine nitrogen, that is very simple, that impaired mental status, and SARS, age, and presumably effusion. What I have said, that is a severity assessment tool as well as the pleural effusion simple. So this is very simple things. We can make some quick assessment of the severity of the patients by these two simple scores. There's a lot of scores, ransom score. I'm not going to details because already it's too late. Ransom score, there's some score is there. There is Marshall scoring system. There is some CT finding also. It's very guide us to assess the severity of the patients. So this is the thing we can use different setups and those are available. And this general, I can if forget that score, it is a very simple score that is 60, obesity, and more than 30, and comorbidities. This three is good enough to make someone a patient of severe acute pancreatitis. So these are the very simple things, but regarding our score or regarding academic setup, we need to go for that sort of scoring system using bicep passive scores. So when this patient has got any patient of severe acute pancreatitis, leave aside the scoring, they should be managed in a monitored care, that is in a good hospital, but possibly it's not possible in our country. But in when setup is available, any case of severe acute pancreatitis, that means the pancreatic symptoms severe symptoms persisting for the more than 48 hours or systemic complications, they should be cared in intensive care. And other things like pulse, that systemic arterial pressure, diastolic arterial pressure is less than more than 120, systolic less than 80 mmHg, and respiratory rate is very high, anuria, coma, and some metabolic causes like hypokalemia, severe hyperkalemia, low hypoxemia, and pH extremes, acidosis or alkalosis in both, they should be closely monitored. The blood sugar level very high, and calcium, as well as the severe hypo or hyperactivity. So any sort of metabolic derangement which might threaten the patient's life, they should be admitted in ICU or in a step about HDU setup or monitored bed. If even if it's not acute pancreatitis, severe acute pancreatitis, they should be admitted or taken care of in a good setup if it is available. After admission, comes the point of management. Regarding management, I must say that three important things. Three important issues: the fluids, pain, nutrition, antibiotics, others, and monitoring. So regarding the fluid management, this is I think the one of the cornerstone of the management of the acute pancreatitis, because these patients have got a lot of fluid deprivation due to the catabolic state. There is a third space loss, there is leakage of the pancreatic duct sometimes. Patient nausea, vomiting, GI upset might lead to the fluid replacement, fluid deprived status. And this severe dehydration or dehydration itself is a very important contributing factor causing deterioration of the acute pancreatic patient. Even the simple mild case may land into the area of severe acute pancreatitis, because if there is hyponatremia, hypovolemia, that might lead to the hypoperfusion, that might aggravate the vascular loss of arterial supply. The skin will increase, there increased chance of thrombosis. So a lot of happenings there. So fluid replacement is one of the important cornerstone of the treatment. Even the fluid may reduce some extent the pains, because lack of fluids might lead to this aggravation of the pain. So we have to give enough fluid. And this fluid should be targeted to reduce to improve the hemoconcentration within at 24 hours has been it should be reduced as much as possible, keeping the patient's safety. So necrosis pancreas so these are the things we have to look regarding fluid. And the fluid usually we need aggressive management at least within first 1 or 2 days, up to 48 hours, and continuous. And we also begin the fluid replacement. We have to keep an eye by the patient hemodynamic status, his renal status, cardiovascular status, and all sort of. So we should not jump into replacing fluid if the patient heart failure or renal failure. We're very cautious. And the fluid preferred the fluid is isotonic crystalline solution. Initially, it is very usually 5 to 10 ml at the first hour, and gradually it is reduced, and we have monitored every hourly if possible, or at least one or twice daily by doing some investigations. As I've said before, hematocrit and blood urine nitrogen, or at least blood urea in our country, to assess whether the patient is getting enough fluid. So these are the crystalline solutions. But if the crystal solution, which one is our choice? There is normal saline or ringless lactated solution. There is little bit controversy that the ringless lactated is a little bit superior to normal saline, because there's some studies that say that ringless lactate causes directly reduction of the inflammation of the pancreas that might reduce the level of even CRP. Though there is some other contradictory reports or publications that might be equal, might be no difference. But still, it is the preferred practice to establish Lingus lactated solution, depending on the at least few evidences are there. But we should be very careful whether the patient has hypercalcemia, because Lingus lactate contains calcium, so that might increase the level of calcium in the bloods. That might lead to deterioration of the patient's the clinical status. So these are the better one. And as I said, during our fluid replacement, we have to focus, are we giving enough fluid or over or under correction? If the heart rate comes below, that is our target. So yes, the patient is getting appropriate replacement. If it comes below 120, arterial pressure sometimes we might miss, but that arterial pressure 65 to 85, if you ICU, you can measure arterial pressure. Urine output is good enough to maintain an output per 0.5 to 1 ml per kg per hour, and hematocrit is coming down, that's below 44%, and blood urea nitrogen is coming down also, particularly if they are high at the onset. So these are the few points we have to do during replacement of the fluid in acute patient. Regarding pain control, the pain is another important topic. I have seen in the picture the patient is really fighting for his pain, which is pain. This sort of patient will need to be very aggressive in pain management. Better, the opioids the preferred option, as naturally that fentanyl and hydromorphone, but morphine is little bit less preferred, because that might cause also the contraction of the pancreatic sphincter. Sphincter override, that might cause some complication. Still, that is a choice in our country. But nowadays, it is common that fentanyl is preferred than other ones, because it is easily that quick in action, less side effects, and it is available there. Then another important issue is nutrition. This patient is catabolic stage, getting no foods, they're starving, lot of issues. So the nutrition is another our important focus of interest. This but which one? It's a oral, enteral, or parenteral. So regarding there is paradigm shift of nutritional recommendation. The American Gastroenterology Society Association that recommended that in case of pancreatitis, we should start as early as possible the oral feeding, if possible, if there is no other contraindication. So the mild pancreatitis, which I have said before in our CBATSS classification, the high dehydration alone is good enough. No need to start parenteral nutrition, no need to start enteral nutrition. When the patient is settled, in 1 or 2 days, we can switch to oral diet to make his to maintain his nutrition. But if there is moderate to severe pancreatitis or some other severe complication, sometimes it's not possible. the patient condition is not improving, there's postprandial pain, there's abdominal distension, there's vomiting, something like that. In that cases, we might need to give some support, like in the form of enteral or parental nutrition. But enteral nutrition is much preferred than parental nutrition if possible, because that causes the integrity of mucosal barrier. There is no leakage. If there is a parental nutrition, there is leakage of microorganisms through the mucosal barriers, leading to that even infection of the pancreatic mass, which is already inflamed. So parental nutrition is not a blanket recommendation for any acute pancreatitis patient. If possible, we have to give enteral feeding or oral feeding. So that is the things we have to keep in mind. So it depends, as I said already, that it depends on the severity. In the absence of alias nausea, vomiting, that can be as early as possible, patient tolerate. And of course, we have to choice of the diet should be the low residue, low fat, soft diet, provided there is no evidence of IBS and no significant nausea or vomiting. And enteral feeding, there's moderate to severe acute cases, but here is two options, or nasogastric or nasovaginal. But the problem is that nasovaginal tube is technically demanding, it needs expertise to some extent. And but investigation, but some protocols that they have found that both route is almost no significant difference in the outcome of the morbidity wise. So in our setup, we can recommend a nasogastric tube insertion to maintain the patient's nutrition if patient is clinically stable, or there is no clinical contraindication of starting the nasogastric and nasovaginal feeding. So yeah, this is already I've said possibly evidence of parental nutrition that includes the secondary complications that will lead to venous access. We need to skip the oral feeding, leading to mucosal barrier damage, as well as there is bloodstream infections. Chances will be increased if we move on to total parental nutrition. So these things I think that is covered. So if we start our enteral feeding, if we are not we cannot provide the sufficient amount of nutrition to enteral feeding, we have to think of enteral feeding as an adjunct to enteral feeding. So another important issue is antibiotics. I would like to share one comment by our genius, our internist, the grandfather of medicine, that was Sir William Osler. He said the difference between man and animal is that man wants to take medicine, animal does not. So in our country, especially, we are possibly more human than other human in other countries. We are fond of medicines, we are fond of antibiotics. But what really says in our research, in our evidences, the evidence says no role of antibiotic in any type of pancreatitis, any type of acute pancreatitis whatsoever. Only condition is if we suspect the patient got infection, there is complicated in the background of acute pancreatitis patients. Only those cases we have to start antibiotic. But keep in mind, the antibiotic, we can start antibiotic when we suspect. Why do we will suspect? Because patient is getting hyperpyrexia or fever is going up and up, patient could still deteriorating, patient has got pain is increasing, so patient has got infected pancreatitis. In this case, we start empirically, but we should not forget to send the culture before starting antibiotic. We, the doctors, have to start the culture of sending cultures. This is a forgotten chapter in the practice. We have to send the cultures before starting any antibiotic to save our antibiotic armatorium for our future infections. So, if infection, we send antibiotic, a blood culture. If blood culture comes back negative, we have to stop the antibiotic. That is the evidence. That should be the practice. But during selection of antibiotics, we have to be very much careful. All antibiotics are not able to penetrate the necrotic material efficiently, like penicillin, first generation cephalosporin, tetracycline, aminoglycosides. These are not effective in case of acute pancreatitis. So which one are left? That's like which is available almost all antibiotics, cefuroxime, imipenem, piperacillin, clindamycin, ciprofloxacin plus metronidazole. So these groups of antibiotics, when we prescribe in case of acute pancreatitis, we have to be cautious regarding not to start, when to start, and which one to start. So these are the few information regarding antibiotics in treating acute pancreatitis patients. Then about the monitor we have to say that we will monitor the patients that's monitored in ICU or maybe HDU or in a high care unit if possible. So we have to do some tests. We have to keep an eye on urine output. We have to maintain the electrolyte balance. There is hypocalcemia, there is hypercalcemia. The blood sugar may go high, up. So we have to be careful and monitor almost every day. And also we have to look about the abdomen compartmental syndrome. So this is the pancreatitis in general. But if patient develop necrotizing pancreatitis, what to do? This is a flow chart. This is a simple flow chart which you can, if you can give a close attention there. There's if we suspect pancreatic necrosis or suspected infection, we have to store empiric use of necrosis penetrating antibiotic, what I've already said. But if there is, start to obtain also the as well as both way that obtain the CT guided FNAC from the pancreatic tissue. And from the pancreatic tissue, after getting this sample, we have to send the blood stain for culture, gram stain and culture. And after seeing the culture, we have to wait. If it is negative, then we can give sterile care and patient does not need any antibiotics. And patients, we can repeat the FNAC every 5 to 7 days. This is the usually trends. If it is gram culture negative, spirit material shows culture negative, there is no organism, so you have to repeat an aspiration that is good enough to manage this patient. But if there is infected necrosis, then we have to start the antibiotics, and in positive blood, we have to continue. But if patient is clinically unstable, then we have to take the help from our surgical friends, surgical colleagues. But if he is stable, so we have to continue antibiotics. In some cases, there is some minimal invasive surgical endoscopic radiologic debridement. That EPM surgery does not need any sort of debridement. So these are the clues, or these are the steps or approach in treating necrotic pancreatitis. So some cases we need surgery in this sort of pancreatitis patients. So already I've said, but regarding important issues, cholecystectomy. I want to highlight that cholecystectomy. The cholecystectomy is that when we have to do, if there is gallstone in a patient of acute pancreatitis, we need to consult with the surgical friends that we need some surgery. If it is mild pancreatitis, it is recommended to do the cholecystectomy at the same admission. At the same admission, we have to remove the stone along gallbladder, because if we delay to removing this gallstone, there is chance of recurrent attack of pancreatitis even within 1 month. But if the patient is severe pancreatitis, necrotic pancreatitis, and it is gallstone, in that case, we have to delay the surgery at least 4 to 6 weeks after. So these are the basic difference of doing left col or cholecystectomy in case of presence of gallstone. That in case of mild cases, we have to do it earlier at the same admission within 2 or 3 days or 7 days. Or if it is a complicated scenario like necrotic pancreatitis, severe pancreatitis, then we have to delay the cholecystectomy at least 4 to 6 days later. That is, I've already said possibly. This one is our role of surgery in acute pancreatitis. But we have seen our early age of our clinical clinical life, in internship or clinical clerkship. That time we have to start nasal suction in any case of pancreatitis, but this is not recommended. There is no role of nasal suction. There is no role of H2 blockers. Sometimes it also practice dactopine, calcitonin, somatostatin analogs, glucagon, these no roles, and also that sort of things that is should not practice in our daily way. But regarding this indomethacins, that is only role is in case of doing ERCP as a suppository. In summary, so prevention of stent necrosis, the early aggressive hydration. So once I've said before that if we do not give enough hydration, there is chance of leading to necrosis. Prevention of infected necrosis, the early enteral feeding, and the treatment of infected necrosis, antibiotics, drainage, and necrosis. That's all, but I just few important talks regarding hypertriglyceridemia. This is an unusual scenario for us, but in a clinical practice, it is we find some 2 or 3 cases. But regarding hypertriglyceridemia only, the triglyceride level more than 1,000 milligram usually that causes acute pancreatitis. Below 1,000, if it is below 1,000, then thing is that it is possible association but not the cause. But for making the causing the acute pancreatitis, it is expected that triglyceride level should be more than 1,000 milligram, and this triglyceride caused acute pancreatitis more severe than even other causes of pancreatitis. So this is an important, etiological issue regarding acute pancreatitis, and this pancreatitis is caused by breakdown of triglyceride. Triglyceride itself is not toxic. There is pancreatic lipase, when that is activated, they lead to development of breakdown of triglycerides in free fatty acid, and direct activation of this free fatty acids causes direct activation of toll-like receptor and 2 and toll-like receptor 4 by free fatty acid and direct lipotoxicity and acute pancreatitis and leading to systemic inflammation. So I've said already that more than 1,000 milligram of triglyceride are required for STG to be considered as an underlying etiology of acute pancreatitis. So 500, 600, 700 usually is not evidence proof. And I've shown you before that this sort of things you can find general examination, lacrimal retrinalis, megaly, eruptive xanthoma. So these are the few clinical issues or signs we expect in case of triglyceridemia. This is the usual picture. If you keep the bloods on the side, so you can see the lipemic blood at the upper parts of the after sedimentation of the blood, blood cells and then syrups in the lower part of the tubes. And I'm sorry, it is possibly it is not understandable in this small. But I want to say that two things. Two things regarding the management of hypertension-induced acute pancreatitis. The main, unlike other management issues, here we have got two important things to address in the management of triglyceride patients. Number one, there is plasmapheresis. Number two, interestingly, the use of insulin. The use of insulin is very much part and parcel of the management of acute pancreatitis caused by the high triglycerides, because the insulin causes the reduction of the free fatty acid levels, increase the gluconeogenesis. So that causes reduction of the triglyceride. The target of insulin therapy is to reduce the triglyceride level below 500. So that is the usual unusual management. Unlike other conventional pancreatitis, in case of if we find this sort of triglyceride-induced pancreatitis, we have to start insulin as soon as possible, like DK patient management almost. In some cases, if it is not improving or more unstable patient, we have to start the plasmapheresis. These two things is available in our country. So I think in our managing the acute pancreatitis patients caused by high triglyceride, we have to prepare ourselves to manage these two simple tools like insulin as well as plasmapheresis that is being done in different medical institutes in Bangladesh nowadays, at least in Dhaka city. And there are few recurrent pancreatitis I've said before, so I'm not going there. So overall, the mortality at the very beginning, our Dr. Prince have said the mortality is almost 10 to 15%, very correct. So these are the mortality rates. That's very high, I will say, because there is more mortality, a significant number of mortality if we compare their clinical scenarios. So there are a lot of system complaints. I'm not going there. This is different issue. And with these few words, I like to conclude my talk. Thank you very much, and thank you very much for bearing with me. Thank you. Assalamu
Thank you so much, sir, for your amazing presentation. I can see the whole comment section flooded with many questions. Now it's time for the question and answer session. But we won't be able to answer all the questions. We'll select few as the time is short. So, without any delay, may I request Dr. Fahim sir to start the question and answer session. Dr. Fahim sir.
Thank you, Dr. Prince, and I especially thank to Professor Arafat sir for his brilliant and elaborative and informative presentation regarding acute pancreatitis. It is now the time for the question and answer session. The box is full of questions. As time constraint, we cannot take all. I would like to take some important questions to the presenter. A question from Munadi Al Islam, who's from Dhaka Medical College. He asked, how will we approach to diagnose underlying carcinoma causing repeated acute pancreatitis?
Okay, thank you, Dr. Munadi. The thing is that regarding the I've said that there's some causes of recurrent acute pancreatitis. The one of the cause is carcinoma of pancreas. So carcinoma of pancreas, if it's a background history, there's some predisposing condition. This gentleman, what I have seen in this picture, who is presently under our care in our Congo University, he is basically patient of carcinoma of pancreas. So basically, when we come this sort of back up in these patients, we do some screening test very beginning, whether there is some markers like acute pancreatic carcinoma CA19.9 that is expected to be very high. That patient background history is there might be some due to pancreatic carcinoma. He might have got some mutation, cachexia, what is present in our patient. And in addition, we should we should not miss doing by pancreatic carcinoma by doing an very meticulous imaging like MRCT and MRI. MRI, I've said that can detect the carcinoma on a very small size. So it's dynamic MRI that will help us to find out the carcinoma in supporting with the clinical backgrounds as well as in the markers blood test if we do for that on the background history of any risk factor of developing this pancreatic carcinoma. Our gentleman is like our gentleman. He is he has a basically he was a history of taking alcohols, lot of alcohols. He's from some part of district, neighboring district where it is very I mean, prevalent. So this sort of approach clinical, then some blood sampling test, then imaging. Okay, like MRI. Ultrasound sometimes miss that. Thank you.
Okay, thank you, sir, for your answer. Munadi has another question. That is, when we should start thromboprophylaxis in acute pancreatitis? Sir.
Okay, first question is that thrombophylaxis. It is another neglected part in our day-to-day practice. Any critically ill patient who is admitted, we have to start thrombophylaxis if there is no contraindication. This is very common because we know the pancreatic diseases. It causes a lot of thrombotic might lead to thrombotic conditions. So if any pancreatic acute patients lead to prolonged bedridden, long to be stay long, we have to start thromboprophylaxis in the prophylactic dose if there is no other significant contraindication. Thank you.
Thank you, sir. Uh, I have got
Should I
another
stop screen
question.
sharing?
Yes, sir.
Should I stop screen sharing?
Yes, you can, sir. Please.
Okay, please. Sorry.
Sir, another question from Hasib Sakib. He asks that is there any role of supplementary pancreatic enzyme on acute setting?
To be honest, there is no evidence. There is no evidence that cause any beneficial role in case of acute pancreatitis. So it is not recommended as a therapeutic tool or therapeutic benefit in case of acute pancreatitis.
Thank you, sir. A question from Arindam Manjumdar. He asked that what is the best management protocol of recurrent pancreatitis of idiopathic cause?
Okay, Dr. Hasib, you have asked the question.
Sir, Arindam Manjumdar. He asked,
Dr. Odin, thank you. Thank you. So the thing is that in case of idiopathic, acute pancreatitis, recurrent acute pancreatitis, always we have to think: are we missing something which is not visible in our common screening or imaging techniques? So we have to give every effort to find out whether there is any sort of conditions which lead to acute idiopathic pancreatitis. Sometimes interbiliary channels problems, there may be some small stone, that might be some small channel dilatations. So in these cases, that MRCPs, that endoscopic ultrasonography, and ERCPs, that is recommended to do, to rule out, to find out any sort of that small carcinoma like this, everything. So even if it is not done, sometimes I've said the biliary sludge and microlithiasis, those are the factors which might lead to recurrent appendicitis, but missing the diagnostic survey. So if there is idiopathic, it is sometimes recommended for cholecystectomy to remove the gallbladder to which might help in uh, in coming out from the recurrent attacks of acute pancreatitis. So possibly that is the answer. Thank you.
okay, thank you, sir. Another question from Rashida Hera. She is asking that what may be the underlying cause and pathogenesis of atypical pain in acute pancreatitis? And she's had another question: how will we manage hypercalcemia causing uh, acute pancreatitis?
Okay, Dr. Rashida. So the thing is that the hypercalcemia management is almost same. We have to find. You can mute the background, please. Dr. Fahim,
Sir, sir,
can you mute the background, please?
sir,
Okay, so regarding hypercalcemia, the basic principles of hypercalcemia is to see whether there is any secondary cause of hypercalcemia, which might lead to this hypercalcemic status of the patient. So it may be some, vitamins, some calcium supplements, lot of issues. If there is hypercalcemia, is there any other cause of hyperparathyroidism, other causes we have to find out. And in the acute setup, the main principle of treatment management is the reduction, the fluid replacement. Already we are giving lots of fluids if there is no concentration. So good hydration will also reduce this hypercalcemia. We can give if there is other tools like neocalcic nasal spray, then calcitonin nasal spray. So we can give bisphosphonates if there is no contraindication. If it's really that high, we can start those. So in these sort of cases, like other hypertensive cases, we can take steps in treating this hypercalcemia in acute pancreatitis setup. Thank you.
thank you, sir. I think I have a question from Shumon Ghosh. Uh, why third space fluid loss occur in acute pancreatitis?
Purpose, Dr. Shimal, that there is the acute pancreatitis, there is some inflammatory changes in the pancreas, there is some damage, the inflammation, there is pancreatic pleural fistula, there is damage on the pancreatic ducts leading to leakage of the fluids in the third space. So it is usually seen in case of necrotizing sort of acute pancreatitis. Where there is necrosis, there is some damage to the pancreas leading to the fistulous tract. That might lead to the third space loss. And due to also inflammatory exodus. Those are the things which might lead to third space fluid loss.
Thank you, sir. I think there are so many questions are there, but due to constraint, last question for you, sir. That how will we investigate and manage SIRS in acute pancreatitis? That is, this is the last question I would like to ask.
For the low
This is
resource setting, you mean that how to manage an acute pregnancy low resource setting, the opposite health complex? So
yes,
it
sir.
depends. Okay, fine, thank you. That is I mean, appropriate question in this in our perspective. So if we go back to our management and diagnostic steps, that first thing is that diagnosis is very simple. That's simple acute pancreatitis, typical abdominal pain. So that is important. Number two, simple serum lipase. Possibly this is available in all part of our country nowadays. Number two, after starting the diagnosis, I've said the two steps are three important. Number nutrition, number one pain management, number two fluid management, number three nutrition. So if it is possible to monitor the blood pressure, urine output, it is also possible. So if we can manage the fluid balance efficiently, that will do a big help to the patient. So give, IV fluid, what we will do, even in Dhaka city also same thing we will do. We will give the painkiller, or pain relief, that is morphine. Morphine, I guess that is also available at least, or if not possible, or better, other NSAIDs can be practiced at least. Number three, regarding nutrition, we have said it is mild, no nutrition support required, just fluid is good enough for 2 or 3 days. In other cases, we can give the digestive tube. Digestive, we can blend food, that means no low fat, low residue diets, low liquid diets. So these three things I think is possible to manage in any setup of Bangladesh. But problem happens if we do need to. It is not complicated. It is not improving, like after leading to necrotizing pancreatitis or the necrotic abscess. In that case, you have to send the patient to a better tertiary center what is available to handle this sort of patients.
Thank you, sir. Thank you for this live question answer session. And
Thank you.
now it is the time to listen from our panel of experts. First, I would like to request our honorable teacher, Professor Ismail Patari sir, to give his valuable comment regarding acute pancreatitis and today's session. Sir, please, sir.
Thank you, Dr. Fahim, for your introduction. First of all, I thank our honorable speaker, that is Sheikh Mahmoud Arafat, for his very brilliant and excellent presentation on acute pancreatitis. Actually, in case of any severe abdominal pain with features of shock, we must think of must exclude acute pancreatitis, where there is abdominal distension, nausea, vomiting, jaundice, and features of shock, and also if there is any presentation. And the most important thing is for the diagnosis. Uh, uh, when we are thinking that it may be a case of acute pancreatitis, simple test. Already Dr. Arafat already mentioned. That is that is the enzymes. That is either lipase or amylase when it is more than 3 times, and investigations if a simple ultrasound as well as if possible that is a CT scan. We can CT scan of the abdomen. We can if we can perform, we can diagnose. And the management portion is very important. That is the fluid management is very important because this patient sometimes go into shock. So fluid management is very important, as well as pain management and nutritional support. That is, gastric feeding is also important. If possible, this nasogastric tube should be placed beyond sphincter of OD, because if um, sometimes that when we are giving feeding by mouth, it may increases the pancreatic enzyme, that may also aggravate the pancreatic pain. And also, we should think of the underlying cause, whether it is due to the any biliary cause. Simple microlithiasis sometimes causes recurrent pancreatitis. Besides, if whether there is any features of metabolic causes, that is hypercalcemia or hypertriglyceridemia, or any viral infections, or any other underlying cause, that should be addressed properly. And even autoimmune causes, sometimes you should exclude. And idiopathic causes, we should also think of if we do not get any underlying causes. So proper evaluation is very important, and recurrent pancreatitis should also be addressed properly, because these patients sometimes go into chronic pancreatitis, where the features of exocrine deficiency, even endocrine deficiency, that is diabetes mellitus, also the features of malabsorption can be there if there is subsequently chronic pancreatitis leading to these features. So, if we can properly manage acute pancreatitis, this related complication we can avoid. So I thank Shoaib Mohammad Arafat for his very brilliant presentation, as well as he gives the question, that is the answer to the questions very brilliantly. And I thank the ACP Bangladesh chapter and also the Professor Nazmul Hassan for inviting me to this session as a panelist. Thank you very much for this
Thank you, sir, for your
wonderful.
valuable, informative comments to us. It will enrich us. And now I would like to request Professor Sheikh Abdul Fattah sir for your valuable comments on today's topics.
Assalamu alaikum. First of all, I'd like to thank Professor Sohail Mahmoud Arafat for his brilliant and elaborate presentation. After his uh, long, elaborate presentation, I think there is little left to comment. I like to emphasize on 2 points regarding acute pancreatitis. First thing is, we may diagnose or suspect acute pancreatitis, but most of the time we usually fail to assess the severity, and therefore we fail to monitor the patient properly. After initial periods of well-being, patients usually get worse due to
So muted again, sir.
Sir, please unmute yourself, sir. Sir, sir, please unmute.
जी जी please host the course. Thank you.
sorry. So my first point to emphasize is to um, identify the severity of the patient and accordingly to monitor the severe patients carefully. Another point I have seen, that is to maintain the failure to maintain the nutritional support. In many of the patients, they do not get the appropriate nutritional support. We cannot use parenteral nutrition most of the time. Sometimes NG feeding provokes pain. So we must give attention to fluid correction and nutritional support. It is already late. I don't like to kind of continue more. Lastly, I like to thank SCP Bangladesh chapter and Bangladesh Society of Medicine for inviting me as a panelist. Thank you all uh, for patient sharing. Thank you.
Thank you, sir. I express my heartfelt gratitude to both our panelists for presenting and giving their valuable comment about today's session. Now it is the time for listening from our Honorable Chairperson, sir. Before going to sir, I would like to express my heartfelt gratitude to SB Bangladesh chapter for arranging such type of program and continuing medical education. And I also express my heartfelt gratitude to Professor H.A.M. Nazmul sir for his arrangement such type of arrangements. Now, I would like to hand over. I would like to humbly request our honorable chairperson, Mr. Khan Abdul sir, to give his final comments and conclude the session. Sir, please, sir.
Thank you very much, Dr. Fahim, Dr. Prince, and honorable to experts sitting, Professor Ismail Patwari and Professor Sheikh Abdul Fattar. And also, I like to give thanks to Professor Sal Mahmoud Arafat, and also thanks to Professor Chibnazul Hassan, our honorable governor, SCP Chapter Bangladesh, and also my gratitude, thanks to the audience, everybody in the show. Truly speaking, it is not very uncommon nowadays. Once upon a time, we could see that making a diagnosis of acute pancreatitis is a difficult task. So there are so many aspects, and you see the very importantly there is your pathogenesis, and it may vary from the condition to condition. And especially you may find that there are so many causes to produce acute pancreatitis, but still diagnosis may be elusive because in some of the cases may not be showing any type of your underlying etiological factors. Once upon a time, it was a very popular term to talk about idiopathic pancreatitis. But Professor Sohail Mahmoud Arafat, he made a very good picture of the underlying etiological factors which may produce acute pancreatitis. And so beautifully it was discussed about the types, severity, and everything about acute pancreatitis, then the diagnostic procedures, and especially the management. It is very important to understand that you see that how he described about the amylase and lipase, and because they are at times when you have to go for amylase and amylase has got many other possible conditions to produce your increased level, but the thing is that lipase is more sensitive and how to make a good diagnosis, and newer types of your markers. The markers are important because that he showed about the trypsinogen peptide, and also some other markers are now under investigation to make a diagnosis of your acute pancreatitis, like your phospholipase A2, interleukin 6, interleukin 8. They are being investigated, and so they are also in future we can make a good diagnosis also under the the different types of imaging procedures. These are very important, as discussed, like ultrasonography, and then endoscopic ultrasound, and the MRCP, and CT scan, and so many things which was discussed. And truly speaking, all are fundamental to understand that exactly in which situation you can go for individual investigation. And truly speaking, at times it may be very difficult to make a difference between the the interstitial pancreatitis and the necrotizing pancreatitis. But the very good ultrasound can give you an idea about the things. and also a very good clinical examination. And from the very beginning, you have to think of the condition that acute pancreatitis can produce a multi-system disorder. So SIRS, and then you see the multiple organ involvement and so many other complications which can occur in the process of your this pathogenetic mechanism and in the course of the disease. So we have to be aware as a physician and when we see a patient of pancreatitis. So everything was narrated. I don't want to repeat those things, but I will say that it was a wonderful lecture, and I like to give thanks to Professor Mahmoud Arafat for his beautiful and excellent presentation. I hope the students who attended the class, if they can make a note on different parts of acute pancreatitis, so it will be very helpful because the things, the diagnostic X-rays and others, it was so beautifully depicted, and so I like to give thanks because they will work in the auspice session. So thank you very much, Professor Mahmoud Arafat, for your excellent presentation. I hope in
Thank
the
you.
future you will be for the students with your more and more presentation. So I hope that will be our treasure. So with these few words, it is more than 11:30. I have taken more 5 minutes time. So I like to give thanks to SCP Bangladesh chapter under the dynamic leadership of Professor H.M. Nazmullah San for making arrangement of this type of discussions, presentations, and bringing our very capable teachers into the focus with this type of presentation for the benefit of the students. Thank you very much. Assalamu alaikum from my side, Dr. Fahim, for your excellent anchoring.
Thank
Thank
you,
you
sir.
very much. Assalamu alaikum.
Sorry, sir, for being late.
Sadly, we have come to the end of today's program. We have learned very, very essential things about management of acute pancreatitis from Sir today. Many, many thanks to the speaker, the chair, the panelist, and last but not the least, the moderator, Sir, for managing time for this program from their very busy schedule. I would like to thank all the audience who were with us. If you joined late or couldn't see the whole program, there is no need to be worried. You will find the whole program on our YouTube channel right after the presentation or the live session finishes. Our next health talk on acute medicine will held on 24th of August, where Professor M.A. Jolil Chaudhary sir will discuss on the topic acute severe asthma. So, see you all in the next episode. Until then, take care and good night.